supposed to do for the opening? Just like 2 or 3 minutes, right? I'll be as fast.
I think yeah, we budgeted like 5.
Okay.
Something like that. All right, it's 11. Let's open the gates, unlock the doors.
Welcome everyone. We're just waiting for the participants to sign on and then we'll get started here in a minute. All right, I'm going to jump in because I know we have a lot of content to cover. Welcome everyone. My name is Anna Barnes. I'm a program director with the Illinois Public Health Institute. We are the co-lead for Data Across Sectors for Health, the sponsor of the DASH mentorship program. This is our second cross-cohort webinar learning opportunity where we bring together all the mentee teams from across the cohorts, and we feature one of our mentors providing some of their expertise and knowledge that's related to the content they're covering in their program. So if you can jump to the next slide. So today we're joined by Karis Grounds and Beth Johnson from 211 San Diego. So I'll quickly introduce you to our program office team, talk a little bit about where we are with the program. Then we'll pass it over to Karis and Beth. We'll have, if we're lucky, we'll have a little bit of time for some short breakout sessions and conversations, and then come back together for a minute at the end. The next slide. I just wanted to encourage everyone to, if you have questions, to contact Miriam. You can send her a private chat or you can email her and she'll make sure to help you with any technical difficulties. Also, if you're comfortable when you're speaking, turning on your video, it really helps us to get to know one another, especially when you ask a question or when you head into a breakout room. Next slide. So this is our team. We're joined by Miriam Castro. Susan Martinez is out today, but Natrina Kennedy is here supporting us on the back end, doing a lot of work, making it run smoothly. So thanks, Miriam and Natrina. Next slide. So just for a little bit of grounding, these are all the mentors listed at the top. And then the mentees that they're supporting this year are listed below. You might see some mentees that you'll meet, some folks from these organizations in the breakout rooms. There's also a lot of synergy and similarity across projects. Next slide. And we do have profiles of all of the teams. If you haven't seen that, let us know and we can connect you to that information. So just briefly, there were some questions on the last cross cohort, so we just wanted to remind everyone that your primary point of contact for the mentor program is really your mentor team. They're your day-to-day support for the one-to-one conversations as well as the cohort learning. We, as the DASH program office, are here for just a couple things. We manage the contract, so if you have questions about your contract, you can contact Susan. We set the program expectations, which are all outlined in the toolkit. We also manage the evaluation and program feedback at any point. If you wish to reach out to one of us with a question about the program or some concerns you're having about your mentor, please feel free to contact us right away. And then lastly, we kind of listen across all the cohorts to collect and amplify the lessons and stories from the program. Next slide. So these cross-cohort learning opportunities are really just a chance for you to meet another mentor. There's a lot of expertise and knowledge among each of the mentor teams, and then also to connect with each other across cohorts. Next slide. So I'm going to pass it to Miriam briefly to talk about the All-In network, and then we'll get into the content.
Thanks, Anna. Welcome, everybody. And yep, just wanted to remind you that as a DASH grantee, you are a part of the All-In network, and you can benefit from being a part of the online community where you can engage with other DASH grantees and also grantees from other partners as well, and benefit from some of these activities such as webinars that we do quarterly. We have a monthly newsletter, podcast, and also the affinity groups. I know some individuals are a part of those affinity groups. And as a high-level recap, next slide. Just want to remind you that you can still join them. They're still open. Just please email me if you're interested, and I can hook you up and get you up to speed. And one in particular, there's one about United Way and 2-in-1 partners, and that one is just getting going. And so if you're interested in that one, let me know. And another one that's closely related is the Reimagining Technology in support of cross-sector referral care coordination. And a lot of these groups, I would say about half of them are staffed by, or I guess led by subject matter experts that are also mentors. So you can also learn from the collective experience of them as well. Next slide. And so I just put a couple of screenshots in here on what the online community looks like if you haven't been in it. And as you can see, the basic functions are sharing resources. There's an open forum where you can put out questions and just kind of FYIs and all sorts of different things we see in there. As you can see, one just kind of a highlight from a meeting that that was had, and a video. And then also you can find your group for your cohort. And so I just put a screenshot here of the 2-in-1 San Diego cohort, and somebody had said welcome in there. So I encourage you and challenge you to find your group in the community and join it and get to know the groups and the resources that are in there. Next slide. And just a couple of reminders. So the main thing on this is if you haven't already, please submit your work plans to your mentor ASAP, and as those will be highly beneficial to guiding your one-on-one conversations with your mentors. So the next slide is where I turn it over to Beth. And so without further ado, Beth, take it away.
Thanks, Miriam, and thanks, Anna and Trina, for putting this together. I am Beth Johnson. I am a consultant with 2-in-1 CIE San Diego, and I work very closely with Karis on our national CIE initiatives. And so we're really excited to talk to you today about our CIE model and stages of adoption, and present some core concepts that hopefully you can use in your work. Next slide. So here are the learning objectives for today's webinar. I don't know how many of you have downloaded or accessed our CIE toolkit, but a lot of the concepts and definitions that we will be presenting today have been updated since we published that CIE toolkit a couple of years ago. So we're looking forward to kind of presenting the CIE model in this new way and sharing this with you, including our tenets, fundamental elements, and core components of the model. And then we'll, and Karis, as part of the presentation, will define and provide examples of community-driven approach to care, as well as provide a little bit of guide and planning efforts to gauge CIE readiness in various stages of adoption. Next slide. So what is a community information exchange? So I think what's important to note here is we really emphasize the community-led aspect of a CIE. It's an ecosystem comprised of multiple core components, including a multidisciplinary network of partners, a shared language, resource database, integrated technology platform, and community care planning. But also core to the CIE is that it affects communities in many ways. It has multi-level impacts, ranging from the individual to the agency to the larger community of care. And the goal of the CIE is to shift away from a reactive approach to care to a proactive, comprehensive, person-centered care. And the diagram that's on the right really represents what the CIE is and why we're doing this work. So we use the graphic on the right to illustrate and ground our intention behind the CIE. So when planning and building CIE infrastructure, at every step, we should be questioning, who are we doing this for and how are we going about it? And so as you can see, the image on the right has 3 layers to it. So the outermost circle represents the tenets or beliefs that drive the intention of CIE, and that's around equity and anti-racism. And so here we state that the tenets of equity exists when all people have the opportunity to thrive and no one is systematically held back from achieving. And in the case of the CIE, no one is limited in achieving comprehensive health and wellness because of their social position or any other social factors or determinants of health. And then the benefit of practicing anti-racism is that it offers opportunities to reimagine ways of understanding and addressing human needs and thinking beyond the scope of the current systems, which have been oppressive to many populations and communities. So absent those 2 tenets of equity and anti-racism, there is risk of 3 things. The first is developing a system that puts the needs of the organization before the community members it serves. The second is exploiting historically neglected and underserved populations that should be guiding the design and direction of the CIE. And the third is harming instead of uplifting the community it serves. So we really, in rethinking the definition and kind of building it out more, we're really emphasizing this equity and anti-racism lens. And then in the subsequent slides, I'll go into the foundational elements and core components that are in the innermost circles. Next slide. So this table really defines what a CIE is and isn't, because I think in our work, there's still been a little bit of confusion around or conflating kind of what systems are really practicing the tenets of the CIE as I've defined earlier. So first to note is a CIE cultivates trust and capacity within the community. So coordination and collaboration among community members and sectors that serve them is really key to ensuring more equitable access, often facilitated through technology. But a CIE is not a specific technology or platform, nor is it dependent solely on technology to connect individuals to services and resources. Technology, the distinction here is technology is a core component, but not the solution. The solution is a multifaceted approach that requires a commitment to equity and anti-racism. And then health-related social needs cannot adequately be addressed by an off-the-shelf technology that does not adapt to and grow with the local community needs. It can't adequately be addressed by electronic referrals alone, but referrals are a modality used to address individual needs, but not a solution. Secondly, a CIE cultivates or enables individual agency and understands root causes of resource gaps. It really aims to incorporate an individual's or family's wants, priorities, culture, and capacity into care planning, while also being sensitive to the trauma and systemic oppression that clients endure. And the CIE is really meant to empower clients at every interaction, ranging from care coordination to data usage to addressing root cause issues while aiming to reduce potential harm and exploitation. A CIE is not a referral centric, nor does it promote a one-size-fits-all solution for data integration, similar to how I stated previously. And then we state that health-related social needs cannot adequately be addressed by a singular focus on the implementation of a closed-loop referral system. So it's really much more, it's bigger than that, it's the full ecosystem. Third, it drives system change. So the CIE focuses on individual, family, institutions, and the community at large. Its role in the community is to support the local infrastructure, create sharing and coordination across sectors, and share data to inform policy change that benefits the community and facilitates investment back into the community, and really driving home that the CIE is accountable to the community. It's not intended to solve, the CIE is not intended to solve one issue. The goal really should not be on solving for one organization or sector, but for the entire system of care. The CIE is a community-led collaborative. Again, equity is a core tenet. The aim is for the function of the CIE to build data for the public good, which could function like a public utility and which would equally distribute power. The CIE is not just led by one organization alone. It's not led by one partner or sector, nor is the strategic direction dictated by the desired outcomes of one sector. The health-related social needs cannot adequately be addressed without community engagement or an explicit focus on equity. And community buy-in must be generated, and incentives should stem from the community, not business objectives. And then lastly, a CIE is designed to uplift and assist in providing agency to communities who experience the starkest disparities and inequities. So outcomes and impact are defined by the community, and the community can set the terms of how health-related social needs are addressed and who they're addressed for. And then aggregated and disaggregated data goes back to the community organizations and members for interpretation and use for advocacy. A CIE is not centered around institutional goals or interests. Again, it really goes back to the community. And then so pause there. So that kind of like goes, is kind of an overview of kind of the main ideas behind what goes into a CIE, and then kind of some misinterpretations in the past that we want to clarify in the right column of what a CIE isn't really supposed to do. So we can have time later on to discuss that, but go to the next slide. So these are the fundamental elements and concepts. This was in the middle circle of the graph on the defining slide. So the middle circle represents the fundamental approaches that drive all aspects of the CIE visioning, planning, design, and implementation. So person-centered, meaning centering the individual and family goals, motivations, and urgencies is core to the CIE. And the person-centered focus on prioritizes value in meeting the needs of individual and family rather than institutions or organizations that serve them, as I mentioned earlier. Another fundamental approach is community stewardship. So again, the CIE must be led by the community through a neutral convener or backbone organization or a leadership structure that ensures community voice, human-centered design, shared power, and partnership in the network. And this governance infrastructure ensures data stewardship, collection, and use that meets ethical standards and shares value with community members that traditionally institutions benefit from. And then the third is multi-level impact. So the role of a CIE is to support the needs of the individual or family, that's the micro level, access organizations, that's the meso level, and institutions in the larger community, the macro level. And so a CIE is responsible for sharing and using the data to highlight inequities, as well as understand improvement and needs met. And so the data should be used to design community level interventions, as well as inform community level investment and policy. Locally, the CIE inspires movement with the goal of systems change, rather than solely addressing needs of individual organizations. And then the other concepts that underlie the fundamental elements and approaches here, I think I've touched on in the previous slides, but again, you want the CIE to cultivate trust and capacity within the community. So there's a big emphasis on community member engagement, You want it to enable cross-sector collaboration, again, drive systems change, cultivating individual agency, and then it's designed to uplift and assist in providing agency to communities who experience the starkest disparities and inequities. Next slide. So the center of the graphic that I showed earlier is the core components. So these are the sociological, operational, and technological constructs that are critical to the CIE infrastructure. And so first are the network partners. Again, it's a community-led initiative. So the CIE is stewarded by multi-sector community-based organizations, including healthcare and government entities who are involved in prioritizing community members' needs and allocation of resources. And partner engagement is guided by a standard participation agreement, a business associate agreement, and participant consent with shared partner governance, ongoing engagement and support. The second is shared language. So the CIE sets a framework of shared measures and outcomes through 14 social determinants of health, using constructs from the comprehensive social continuum assessment. And some of you may have heard it before termed as our risk rating scale. So that's embedded in the CIE, and it determines the immediacy of needs presented by the client, barriers to services, available supports, and the individual's knowledge and ability to utilize resources. Then bidirectional closed loop referrals is a shared and continuously updated resource database of community health and social service providers that's embedded in the CIE. So bidirectional closed loop referrals enable our partner organizations to streamline person-centered care, the delivery of person-centered care, monitor individual progress, and also capture outcomes in real time. The technology platform and data integration, the CIE is technology agnostic. So it leverages an interoperable, customizable platform to facilitate data sharing between other platforms or portals accessible to all providers. So it's really meeting the providers where they are in terms of their own infrastructure. The technological infrastructure allows for proactive alerts and insights to help make information actionable. And then the last core component is community care planning, which I alluded to earlier. So the CIE includes an embedded longitudinal record with a community care plan that promotes cross-sector collaboration and a holistic, trauma-informed and equitable access to care that's inclusive of family needs and strengths. Next slide. So this graph shows our 14 social determinants of health that we monitor within the CIE. And at this juncture, I'm going to turn it over to Karis to explain this as well as kind of the community-led aspects of the CIE. Karis?
Thanks, Beth. Great. So I think Beth kind of gave a good overview of what our community information exchange like primary tenets are and kind of the overarching goal of it. And again, we think about a CIE from like a micro, meso, macro standpoint. So how does it impact the individual? How does it impact the agencies that are working together? And how does it impact the community? And so some of the tenets and like the primary, like almost the value proposition or business reason around why we're doing it is really centered around, sorry, equity and really addressing those health disparities. And so what it really centers though around from the get-go is like moving towards a person-centered model. So again, this is like a systems change effort. And like, how do we start thinking about the individual in the center, taking into consideration a lot of the impacts that we know, the disparities that are impacting certain populations. So that could be anything from, of course, race to poverty to like their backgrounds, trauma, all those kind of things. And how do we center that person's needs around the services that they're accessing? And so in this image, it's just like an easy way to kind of think about, okay, once you center the person, a lot of people talk about it from you might have heard like patient-centered care before, but you're thinking about it in your four walls of your own institution. When you think about a CIE, it's really like, how do you center an individual inside of a system of care, because there's healthcare, there's social services, there's government, there's a whole bunch of ways. There's our own community, our families, churches, businesses. There's a lot of people, things that we access as an individual. And as an individual, in the current state of the way we are treated, it's all siloed and it's all the same. You have to tell your story over and over again, and you have to provide documents over and over again, and people may have not known your history before to be able to address that situation in a more collective and comprehensive way. And so really the primary goals is like, how do you start thinking about the way you provide care in a more trauma-informed, culturally competent and supportive way? And so that's kind of how we have centered it here. And please, yes, ask questions in the chat. We're going to have some time to go through it at the end. If you go to the next slide, Beth kind of alluded to this, but as we're thinking about, and this might address your governance structure question, Andrew, but really our governance structure is set up like a stewardship. So 211 San Diego is essentially like supports as a backbone infrastructure, a collective impact organization, but really it's stewarded by an advisory board made up of organizations in the community, like our hospital association, our health center partners association, our FQHC association, our social service providers. We have like a advisory board that stewards it. We have a network of partners that's now at over 100 that really we meet monthly. And then we have a bunch of affinity groups, we call them, or working groups that kind of target out like what policies, like who gets included in the network, what kind of data should be shared, who should have access to the data. What should the system look like? What screening tools or prioritization resources do we need? How can we kind of learn from best practices across the network? And then one of our other primary, this is like a generalized stewardship framework, but we also have like a community advisory board with community members, people that have been impacted by the services that are provided and have their voice heard to be able to kind of inform our overarching vision. So it's, again, governed within the community, it's stewarded within the community. And it allows for any organization that is join the network to be able to provide referrals to resources that are accepting those bi-directional referrals, as well as using the information in the system to be able to kind of tailor their needs or tailor their situation accordingly. All right, and so some of those ways that shows up into community different approaches to care is specifically, as we talked about, the community leadership structure. So again, we have a shared governance structure. We have community ownership. So it's an opt-in model. We have a community advisory board. We want to make sure we have representation from all types of organizations, community health workers, specific targeted nonprofits that are supporting communities that are often not thought about or not addressed. They might be smaller organizations, those kind of things, to be able to ensure that we're representing and have representation from all populations and all needs of our community. It's tailored by the community. So again, it's we modify and create new technology enhancements and or affinity groups or collaborations specifically around the needs that we have in the community. So there's a lot of things, like, for example, we have a Partners in Prevention network that's specific to looking at building resiliency for children who've had trauma. And so that is based on, of course, that's based on individuals that experience trauma. That's then informed by our community-based organizations are providing those services. That's then informed by the infrastructure of CIE. And so we're able to tailor our system to be able to meet the users' needs and the people that are being served by those needs. What kind of questions are we going to ask? Making sure we're not just screening for adverse childhood experiences, but we're also screening for what makes a family resilient, like what supports have they already used or resourced, those kind of things. And then our CIE is also integrated. So as Beth was alluding to, one size does not fit all. It's not about selecting one technology. It's about identifying a way that we can integrate data from multiple different systems and make it easier for our community-based organizations that are having to leverage multiple platforms and create data structures that allow for kind of that shared language, as Beth was talking about, to be able to, what are the right data points to share across the network? What makes sense for organizations? How is this information used in a thoughtful way? And so that's really how we've thought about it from a community-driven approach. So again, what we were talking about and what Beth's talking about, it's a big this is systems change work, and it's not like we can say this is going to be done in one day. We've been around for 10 years. This started in our downtown San Diego. We have a significant homeless population, and the same individuals were being transported by EMS to the shelter, to the hospital, to jail, kind of being recycled. And there was no communication between these different providers, and the same experience the individual is having to go through that system of care. And so really it started through an innovation idea of like, hey, what if we start asking these people if they're okay with having their information shared and start collaborating together around how we support them. And so that's really how this started. It really started around data sharing and how do we think about collectively working together as providers. And so we are at our 10-year, we're still building towards an equitable model. We've revamped a lot of our language to start thinking about how do we center community members, how do we center the most in need, and how do we really think about a system of care that supports them. So we're still working up this pyramid. But really just like, if you guys can kind of look at some of the core components, we're going to walk through them really briefly. And then I want to make sure we can answer the questions that are, go to the next slide, that are going to come into chat. But level one is really just thinking about like buy-in and community engagement. So thinking about the way that shared values, missions, and vision for the network or collective approach. So I think sometimes communities don't necessarily think about us as the initial step, but your community-based organizations, because a lot of this is based on their needs, you want to make sure that they're bought in and understand what it actually means to be participating in this kind of network and how can they be supported and what's the end all goal and vision of this. So making sure that there's a lot of people are already using technology. A lot of people are already engaging in collective issues. CIE is not meant to replace those things. It's meant to support as an infrastructure. And the way I've been describing it lately is like, it's like an ocean. CIE is like an ocean, and everyone's kind of building all these little pools. And if you could leverage this ocean to support all these different initiatives, we might be able to do better care coordination work if we're actually supporting one another through this larger vision. And so getting people bought into that vision and understanding of the value and the ability to leverage it and having it stewarded by a larger collective is really an incentive to kind of start off there. Moving on to the longitudinal record. So being able to really think about moving towards person-centered records. What is being able to collect the individual record, being able to create the opt-in model is like a second step to that. Thinking about data standards and governance, the stewardship of the information, how and what the information is shared for, the ethical use of the data. People are going to be concerned about opting in to have their information shared. So you want to make sure that it's being stewarded in the appropriate way. Who owns the data? How is it being leveraged? Those are all things that need to be thought through the building of your community information exchange. If you go to the next slide, we're really thinking about like referrals and data sharing. Again, we think about referrals and data sharing completely different. I think by closed loop referrals are absolutely important and a core piece to reportable outcomes around did this person get connected or not, but actual data sharing across systems of care and having information about the individuals that's outside of just sending them to an organization is really empowering and impactful. And so those are pieces, and I know Dash is a huge supporter of that and being able to kind of think through the systems of care, but data integration between system platforms across community sectors is a huge piece to being able to do that. And so maybe we should be breaking these out into two separate boxes, because I think sometimes people are just stuck on the referral part, but really data sharing is about having information from multiple sources to be able to have that informed care plan. And then the shared language is really like, okay, now that we're sharing data, now that we're looking at closed loops, how do we start establishing a holistic understanding of that person's situation? So I think we're probably just moving into this step right now as a 10-year CIE organization is looking at like, how do we actually create shared language? And that doesn't mean everyone's using the exact same tool or addressing the exact same needs, because as we know, the values of healthcare might be cost savings and the values of CBOs might be wellness or other things that we're thinking about, or housing stability or food insecurity. Those are all things that kind of make that up. So it's about creating like shared language across agencies, but it's also about thinking about from a person-centered situation. We can't just be thinking about things as a binary. I'm homeless, I'm not homeless, I'm food insecure, I'm not food insecure. We got to be thinking about it more of like, okay, now that I'm not homeless anymore, we want to make sure you're into stable housing, and we want to make sure there's a continuum towards that work. And so being able to help articulate and understand, there's like, just like moving up a scale of a, healthcare is very like BMI. There's like A1Cs and ACLs. There's like numbers that show like you're getting better and better. We need to have that same concept around a person-centered situation and what those needs are. If you go to the next slide, we are, so level 3 is kind of the really moving towards a community information exchange, but looking at system integrated records, integrating data from multiple different sources, and creating one shared comprehensive record, and being able to have multiple agencies use the CIE for informed care or for interventions. Then we really think about shared care planning. So actually having assigned roles and tasks across organizations is really a goal of how can we actually start sharing care plans so that other people know, okay, I'm working with this individual on these needs as a housing provider, I'm working on their healthcare from this perspective, and being able to collectively, and maybe even other individuals that are part of that family care plan that you could really help to address is like the vision of what that care plan could potentially look like. And then the end all goal is really community care planning. It's going to be multiple organizations, its sectors really contribute and supporting to that individual, and using those collective data to empower and inform community care planning, really informing disparities. Can we start using this data to do investments? Can we start really using this information to really support our local communities in a way that's building capacity and support for the individuals that it serves? So those are kind of high level concepts that knowing that the CIE is not like, oh, you just stand this up in one day. This is a long process, and it requires a lot of thoughts to be able to kind of walk through that. And so we're just going to go, I think we have one more slide, and then we're going to answer some of your questions before we break out into groups. This is really just looking at the common challenges every step along the way. So navigating power dynamics is one of these pieces. So understanding that, as I kind of mentioned, what the goals of different sectors are completely different. And there's not necessarily like a roadmap to a shared language sheet that you can just like, oh, this means this to you, and this is this. So being able to not only navigate, how do you communicate those needs? Traditionally, in some of these circumstances, institutions have more of the power. And as you guys saw with Beth's slides, we're trying to center the community. And so how do we shift that power dynamic to go from institutions making decisions to community members actually being impacted or affected by these services to be more of those decision makers? And so that takes a lot of buy-in, engagement, that first phase in the build out, to be able to understand like, hey, this is what we're trying to do. This is going to take more time. This might take different type of resources. You might not be hearing what you want to hear because you've done it a certain way a long time, but that's really what drives systems change, is kind of changing those dynamics. Compelling value propositions, I think being able to understand how, again, for the different sectors, what value propositions are important, what is your end goal of the system of care, what are you driving towards, and being able to kind of break that down for each different sector. And we even think about it in the social service sector, what housing providers are different than food providers, are different than social isolation providers, are all their goals and their deliverables are completely, and their value is completely different. And so being able to kind of think through what the value is for each sector and each organization. Even in healthcare, health plans have different expectations than hospitals, than health centers. So it's not necessarily like an easy, like, I think when you show the person-centered, you're like, okay, I can buy into that. But then as you're like looking at the investment and the sustainability and the capacity building it's going to require organization to participate, you got to make sure that value proposition is worth the investment of those organizations. So that takes a creative and thoughtful process as a steward of the organization to really identify what those value cases are. Establishing and redesigning of practices is optimal for engagement. So the idea that you build this, it's going to change. We think of it like an agile process. This is a continual thing. It's not going to be the same every year. And those goals and expectations change every year. Like even if we look back 5 years and look at what the strategic goals of CIE, they're completely different every year because we're evolving with the needs of the community. We're evolving with the infrastructure and the support and the community voice and like what community members are seeing. And so being able to really be agile, initiatives, policy changes, all of these things. So again, creating an infrastructure that's like written in pencil is the way we like to say it. Everything's written in pencil, and then it's going to creating an infrastructure to be able to shift those things. And then the shared language, we can't say it enough, is being able to like, not saying that everybody needs one shared language, but really like, how do we think about ways to be able to establish some infrastructure of full understanding around some of these larger concepts so people are on the same page. And I think that gets confusing with like care coordination and care plans. And healthcare might think that this is what they're supposed to do, and social services might be interpreting that same language. So being able to kind of set up some of that language early on and to create a clear understanding of what you mean and be thoughtful about that, as language can be interpreted easily the wrong way, or assumptions might be made on certain language. So being able to kind of think about that as a opportunity to avoid a challenge in the future. So I think the breakouts is the next. Do we want to just take 5 minutes to answer any of these questions before we pop into the breakout groups, Anna? Or do you think?
That sounds good. I think you probably have about 10 minutes for Q&A now if you want, and then we can do the breakout. Let's see. Do you want my help here? Kara's looking at the question.
I got a stream of questions come in. I think you answered Andrew's first question, Kara. Should we start from the beginning? And then Andrew had a follow-up question of who gets care through the CIE? Karis, do you want to go through the consent and all that?
Yeah, sure. So the first question is, sorry, I'm trying to read through this. So so the 211 database, every organization in the 211 database that use for 211 calls I would assume individual 1,000 organizations, or does CIE only make referrals to organizations who have signed the phone? So of course, 211 makes referrals to any provider we have. So in the 211, in our CIE platform, we leverage our 211 database to be able to, so we have like indirect referrals and direct referrals. Indirect referrals means you're just tracking that an individual, you gave a phone number or address to that organization to provide that, to go to that service. A direct referral means that your information is directly shared with that organization. They've joined the network and they're participating in it. So CIE organizations only make direct referrals to organizations that are in the network because they're agreeing, they can log into the system. They've already taken the training and the security, and they're going to make sure that they've protected the information in the right way to be able to access that database. But we list any organization that qualifies under our inclusion, and they're listed in the database as a referral, which is similar to most of the technology platforms that are out there now. Is it anyone who calls a 211 line, or is it a specific group of people identified in a way? So currently we consent who gets care through your CIE. This is what Beth was just saying. I mean, everyone, so we have over 200,000 individuals that are consented into the CIE. And that is not just through 211, that's through when they access housing, the housing services, homeless management information system consented to the CIE. When they go to the food bank, they consent in the CIE. So any shelter organization, they're consenting into the CIE, or many federally qualified health centers. So there's lots of different instances. Our county, as a county is referring to outside programs, they're also getting consented in. So it's really at point of care. And there's two ways that people can access someone's profile. It's really about, I've been referred. So I've talked to the individual and I've said, hey, do you want to be referred to the food bank? The individual says, yes, you're going to send that information over. Or that individual is accessing services from you. So I'm calling the county, or I'm going to Father Joe's and I'm accessing services. So they're now my client or patient. Now I can look them up in the CIE. So there's two main functions of it. Care in the CIE means your information is shared. It's not going to assign you a case manager to do. They can call 211 at any time to access services, but it really just allows your information to be shared, and any one of those organizations can leverage the platform to support the individual differently and make referrals on behalf of them. So once you're consented in, you're able to be navigated through the system using that infrastructure, but it's not like you get a special navigator or someone to do that. And unfortunately, that's just because that's the way our system works. It's a lot about, you have to qualify for a navigator based on your mental health status or behavioral issues or some acuity of care. But CIE is leveraged to be able to support those initiatives. So if you're a complex care provider, you might leverage the CIE to coordinate your care better. So it's leveraged for a bunch of different ways. Does that make sense? Or Beth, do you want to articulate anything I'm missing?
No, that makes sense to me. I don't know if Andrew wants to come off mute and see if that makes sense, but
yeah, that
that
does make sense, guys. Thanks a lot. That's very helpful.
Okay, cool. Great. Thank you for the great questions.
Can I just confirm that when you say consent in, that is an active consent? It looks like Gary is suggesting that you have a written agreement that is something signed by the user who is consenting in. Is it formal on record?
Yes, we have a formal on record. It's available in our toolkit. We have a standard authorization that we use across these different providers. In some circumstances, it's modified if it's joint with some other consent, but the core pieces of that consent are included into it. So yes, we have a copy of the agreement inside of the CIE once an individual consents in.
And
I
then
think maybe, I was going to say maybe that one more question about the technology that you use or what platforms you use, and then we can go into the rooms. And you don't have to do my question, Beth, or we can do it when we come back together too.
okay. So we use Salesforce, a highly customized. So Salesforce is the platform, but it's highly customized to fit the needs of the community. And we use a middleware called Informatica that talks to different systems that our community partners are using. We felt that it was really important to meet our community partners where they are and not require them to sign on to a specific system, but for them to let us know what their workflows are, what systems they're working on, and figure out a way to plug them into a system that can talk to everybody. So, Karis, do you have anything to add? Did I explain that correctly?
Perfect. Yeah. No, I think it's perfect.
Great.
So Charles is asking Beth and Karis, do we want to pause and pivot and just keep everybody? And it sounds like there's a lot. This is kind of feeding more questions, and so I think there's an interest in maybe just a general Q&A.
Sure.
And okay.
Yeah. Sure.
Great.
Let's
So
do it.
So maybe just, reflecting on these questions, if anyone wants to weigh in, like if your community, where your community is at building this or at adopting it, anything else that we can answer, or is there still questions that we haven't answered in the chat?
Yeah, there are a ton.
I hate self-serving, but can you address the question about cost and potential funding? Because we are having a heck of a time finding funders who will fund something like this.
Yeah, sure. Well, that's too bad. I feel like there's a lot of work being done around this work. We do have some tools that we use to help create a business plan. Beth and I put together like a pre-CIE roadmap that kind of thinks through. It does require, regardless, if you could get a foundation or somebody to help with some of the startup costs around planning. Through we have a membership that you can participate in, and that gives you access to those type of tools and resources that might be helpful to be able to kind of build a business case. But I think that's kind of the pre-work that's required from a lot of these different infrastructures. And again, we have a blended braiding model. So we started through foundation support initially, and then as it's grown, we have a membership fee for healthcare providers to participate. That's kind of paying into the infrastructure of it. We have contracts and grants. So other organizations are writing us into grants as the infrastructure for collective impact, like work for like ACEs or, whatever kind of initiative that's happening within your own local policy or initiatives. And then, so we kind of have a multitude of ways that we fund our CIE. It's not from one healthcare organization, but it's through multiple. So I think that there's a lot of opportunities and interest, I think, now around this work. So but happy to send some information as a follow-up too. Beth, does that seem right?
Yes, we covered it. Anna, how did you want to do the questions? I see Jim has his hand up. Should we go to Jim and then go back to the list of questions?
Do you want, Trina, would it be easier if we just take off the slides and maybe go into the view where you can see everyone, and then you can kind of see
Sure.
folks that are, okay, let's do that. So go ahead, Beth, with Jim's question, and I'll go back through the list and see if we missed anything in the chat.
Okay, I put a question in the chat and then I got nervous, so then I put my hand up. Thank you for seeing that. I'm with the South Cumberland Health Network. We are in a low wealth, under-resourced rural community in Western Central Appalachia. And we've got a university that connects with us that's interested in being a kind of helper backbone organization. We've got a small community fund that is able to generate some capacity building money. Weirdly enough, we decided that our municipal 211 near us in Chattanooga wasn't helping us enough. So we have been working with Aunt Bertha, findhelp.com to kind of get information that's sort of local so that we can start building collaborations around information sharing. So we're at stage one with all this, and quite frankly, looking at what you're doing, it's like I could imagine a future. So, but what I'm curious about is whether you've seen this kind of project actually launched in a low resource rural community.
Yeah, we can. So so through our mentorship, so we've been doing the mentorship with Dash now for 3 years. So there's been a handful of organizations that are in more rural communities that are kind of looking through it. In some ways, it makes it easier. In some ways, it makes it harder. I think to your point, like how do you find foundations to support it? I think that in rural communities, they've leveraged relationships with bigger counties or bigger cities to help to fund or get support for those smaller resource organizations. So being in collaboration with other counties to see what they're oftentimes are looking at systems like this. So being able to leverage that. And then in some ways, your cost might be a little bit less because there's not as many organizations, or you kind of might have all the key players at the table to have some of these discussions quicker and easier, because you're not navigating thousands. Like in San Diego, there's 7 health plans with 10 different hospitals with 15 different federally qualified health centers. That's just on the healthcare side. And then we have thousands of nonprofits. So being able to like navigate all that, it makes it more complicated versus in a rural community, you might be able to have a quicker infrastructure and setup in a way that might be less resource investment. So I think that, being able to make some of those business cases and being able to kind of highlight the why of and the value in rural communities of the need sometimes makes more sense in a lot of ways too. So, but we're happy to point you to some communities that we've worked with previously that are in more rural settings. And I know Humboldt is one of those. I know Martin's on the call too. We can connect you guys to maybe talk about what their experience has been. And they've been around for a long time. They're OGs.
Great, thank you so much.
Martin, did you want to share anything before we take another question?
I think the point that rural communities are simpler is very much a good point, and I think that's a place to start. Also, we certainly do not have a lot of resource. The benefits of the CIE have been compelling to the local funders that we have, and that's been pretty successful for us.
So I think thank you, Martin. Appreciate
I think
that.
Nick has his hand raised too.
Okay, great.
Sorry, there's a lot of people with a lot of questions. Karis, I'm just curious, with 211 and United Way and the data collection, And how do I put this? Like, in the social sector, we're looking at this through kind of the altruistic lens of like, how do we do the most? I asked a question about Unite Us in the box, and if anyone or yourself is working with them. And I'll be blunt here, is it's a for-profit company coming in to monetize this data now. And I'm just kind of curious about what your vision is or your work with there, because I am with United Way as well, a small, located in a very remote region that is rural, whether people understand that or not. And I'm just kind of curious what your experience has been with them, and kind of how that relationship works, if you guys have one. Thanks.
Sure, great question. Yeah, so we've, a long time ago, we had partnered with Unite Us in our Veterans Network. So we've leveraged their tool before. I think there's, we've partnered with them in some ways. I think it's more about like the vision of what you're building. So it's like, what is your end game? And again, Unite Us, Aunt Bertha, a lot of these tools are bi-directional referral tools. So these are, and as you guys look at the pyramid, like you're on your way towards the top. So I think it's about, how do you think about, to your point, Nick, like what's your altruistic motive? Like, how do you actually think about building a system of care and what that actually means? And in our approach, I think we're like, you have to have community governance, you have to have community buy-in. So if the technology to me is like, it's to us, is agnostic, regardless of, your platform. So how do you create your role to be able to be leading that work? And how do you ensure that the information is being shared? What questions do you ask that technology platform? But the decisions around technology, I think right now the issue is, I think you're bringing up a good issue around for-profits. Who's leading the work? Before you decide a technology, there's a ton of pre-work you need to do to even bring in a technology. So I think what our role is to really educate. And we are trying to do that around what Beth was talking about earlier about like, what are the tenants? What are you building? We're trying to be better advocates at explaining the role of organizations like us in this work. And you can't assume the technology is going to solve these systemic issues. I don't understand how that can be some of the assumptions, but I think it is, because I think there's a lack of understanding and awareness about it. So being able to really ask those questions. Again, we have a toolkit that's free that you can download. We have a summit coming up in September where we have a lot of these conversations, but being able to kind of think through like, what is the pre-work? So when technology is coming up within your community, being like, I get it, we need a technology, but how do we start having like, what are we designing for? What are we building for? How is the information, like what's meaningful to the community on, to your point, data ownership? How do we ask those questions to technology vendors? So when you do have those questions, when you have established your CIE like infrastructure, you're picking the right technology platform that is addressing those concerns or thoughts through your through that platform, I guess. So we're not, again, Unite Us and Bertha. I think a lot of these tools can be nice to have out of the box kind of tools to be leveraged, but being able to really think through making sure that that there's a full understanding of what the end all be all is, and then also that the technology could change too in 5 years. Are you to the point of like, are you only building a bi-directional referral platform? Are you building a community care plan platform? Are you going to invest in this now? Do you want to invest in the future? So as a community, those decisions need to be made. But right now, I think everyone's like, let's buy a technology to solve systemic issues. It's kind of like, doesn't make full sense. Did I answer your question, Nick? I don't know.
Yes and no. I think it just really goes into the fact that there's competition in this right now, and that's just a concern about. And I'm thinking of it once again from the United Way standpoint, and kind of not realizing the value in the data that we have, at least in some of our smaller organizations. And you have a for-profit company coming in that is now valued at $1.5 billion that is leveraging that data and that resource and those key relationships. So maybe it's just me and my non-rose colored glasses and thinking that someone's basically monetizing it rather than doing for good. And I was just curious if you had any kind of interaction with that, but I appreciate the analysis on the data and kind of that top down, what are they actually looking to do? And that's kind of a moot point. Let's focus on some other things. So I appreciate that.
Great. Well, thank you, Karis. I think that was a really relevant way to tie up this presentation. And just want to share again that the affinity groups are having some of these conversations, particularly the Reimagining Tech group and the United Way 211 group. So Nicholas, that might be another space to kind of keep asking those questions and unpacking what other communities are doing. Thank you all for joining. 2 quick announcements before we sign off. The national call for proposals for the All-In National Meeting was extended until June 25th. So we encourage all of you to consider submitting, reach out to us if you have questions or need some coaching or support around what you could submit. And then Karis mentioned the CIE Summit. So if you are a DASH mentee, which most of you on here are, we have a set small number of scholarships to sponsor folks to go to that summit. So reach out to Susan. We'll be sending out like a request form for that. And yeah, I think that's it. Thank you so much for joining, and let us know if we'll be compiling the chat and also the requested resources. So give us a little time to put that together and send it out. Thanks, Karis and Beth. We appreciate you taking the time to do this for everyone.
Thank you for all the wonderful questions, and we'll try to follow up with some of these in the online platform too.
Great, thanks, Beth. Awesome. Bye-bye, everyone.
Bye.